Hello everybody, I am Indrani Roy. The title of my talk today is COVID-19 Crisis, Influence of Temperature on the Global Spread and Alternate Exit Strategy. What is the motivation of this research? More than 41 lakh people died till 18 July 2021. Economy and mental health suffered tremendously. No proven cure for the disease is found yet. Though mass vaccination started on 8 December 2020, but there are many limitations. Considering that emergency situation in mind, some urgent, simple solutions were proposed as early as 17th March. It is purely based on science. The solutions are practically without side effects. No funding is required and can be practiced in own home. There is no vested interest. Now, outline of my talk. First, I'll give some analysis of initial period of the data for global spread of the disease. Then I'll cover temperature sensitivity of the virus, some statistical analysis and clinical trial results. Then I'll move to solution part. Then analysis of post-vaccination period. There I'll cover insight from flu and mutation of virus. And then I'll discuss whether we'll go for optimism or pragmatism. And then I'll summarize my results. Here is some analysis of initial period of the data for the global spread of the disease. It is a temporal pattern of rolling 7-day average of daily confirmed COVID deaths per million, and it covered period up to 6th of May. What we can see here that India, Asia, Africa and Australia all are very low, and those are practically merging with the x-axis. Whereas bottom three curves, you can see the three curves, they are showing rising trend, and those are for Russia, Brazil and Canada. Whereas top four are high peak curves, those are for UK, USA, Spain and Italy. All four are showing declining state in May. Now, obvious question come to mind, is the pattern still maintained? If more countries are included and it covered till July 2021, what is the answer? The answer is, in spite of various peaks in different countries with varied amplitude and timing, that ranking of countries are still valid. Here is cumulative deaths and cases per million. Top one is for death and bottom one is for cases. And top group shown by yellow is for moderately cold countries in winter. The middle one is for very cold countries in winter, those are Russia and Canada. And bottom one shown by blue color, those are warm countries, and India, Indonesia, Africa, Bangladesh, Pakistan, Australia, etc. What we can see from this temporal pattern that Europe and USA, there is a steep rise in cases and deaths in winter. Trend was practically nominal in summer. Here you can see that there is a horizontal part, horizontal line for all these cases. And in all countries, those trends in summer were 2020, what was nominal. And it suggests that seasonal temperature is important and can't be ignored. This is average global air temperature plot from mid-February to April 2020. That period, COVID disease spread all over the globe and almost all countries put strict lockdown measures. What we can see here, those who are moderately cold countries, they showed major vulnerability. Moderately cold countries are shown by green, light green, whereas very cold countries are shown by purple and blue, whereas red and orange are showing warm countries. Warm countries are shown here, African continents, Australia, Southeast Asian countries, and SAARC countries, whereas very cold countries here shown as Canada, Russia, and Scandinavian countries. Is the analysis sensitive to different air temperature measures and different data sources? We tried with global 2-meter air temperature and used different data sources, but temperature dependency was similar. Now, global temperature analysis till 1st of May was compared with the vulnerability measured in deaths per million. For moderately cold countries, temperature threshold approximately between 2 degrees centigrade to 17 degrees centigrade was the most favorable state for susceptibility of virus. Countries like USA, UK, Spain, Italy belong to that category. Countries with very cold temperature, say less than 2 degrees Celsius, were moderately affected in March to April. Those countries are Canada, Russia, and Scandinavian countries. Warm countries and places with temperature threshold roughly above 27 degrees Celsius were likely to be less vulnerable. For example, SAARC, Southeast Asian countries, African continents, and Australia belonged to that category. We also showed risk from the virus were reduced significantly in very high temperature environment when temperature is above 32 degrees Celsius. Parts of African continents and Australia belonged to that category. Now this is a statistical analysis for deaths per million till 1st of May. What we can see that there is a difference among category 1, those are moderately cold, shown by left hand side, to that from category 2, which are very cold countries, shown by middle, and category 3, which are warm countries, in the right hand side, those are shown. And the average value of death per million of those countries are considered. Uncertainty in 1 standard deviations are marked. What we can see, the difference between these 3 categories of countries are statistically significant. And if we include more countries, the result is similar. What are moderately cold countries? Those are USA, UK, Italy, Spain, and France. What are very cold countries? Canada, Russia, Finland, and Iceland. And warm countries are SAARC countries, Southeast Asian countries, African continents, and Australia. Statistical analysis was further extended for all SAARC and Southeast Asian countries up to 1st of May. What we can see that there are varied characteristics of all these countries. Among those are popular tourist spots, international business hubs with more foreign travelers, level of testing, infrastructural facility, population density, different degree of lockdown restriction. But one most important thing is that in spite of all dissimilarities, still one common factor, that death per million for all those countries from SAARC and Southeast Asian countries were much less, and the pattern is still maintained. It was lesser than 8 till 1st of May, while in Spain it was 531, in Italy it was 467, and in UK it was 405. Because of the large population, India was, however, one of the highest ranked during August in overall counts of total deaths as well as cases. Here we'd like to show that countries can switch from one vulnerability state to another based on variability of temperature. This is a mean air temperature plot in March shown in left and April shown in right for Europe. Data taken from NCEP and Curry analysis. What we can show here that Europe turned warmer from moderately cold and death rate decreased from March to April 2020. The same pattern is observed till August. Also for South American countries like Brazil turned warm to cooler in June 2020, while Canada, Russia from very cold to moderate cold. Death rate increased in those countries. We can also provide future predictive maps. Those are generated based on climatology, which is 30 years average of global temperature. Here the result for July is presented. It indicates which countries are in advantageous or disadvantageous state in coming months based only on temperature variation. It is very useful for country-wise future preparedness. For example, South America, Australia, South Africa, etc. will turn colder and need additional risk-based preparedness, whereas Victoria from Australia usually most affected in July. We can also verify July 2021. Here you can see all these countries are lying in the green and light green zone. This family of virus is very sensitive to temperature is shown by various statistical analyses. Number one, it is short for SARS-CoV-2 that is responsible for COVID-19 is shown in various studies by Scafate, Paula and Roy. Paula et al. In a review work presented 16 recent papers on COVID-19 and all found strong connections of temperature. This is also true for similar generic coronavirus SARS and MERS. It is also true for other similar seasonal airborne flu viruses. There are some results from clinical trial experiments. Loyan et al. Did some study using seasonally dependent endemic virus. They showed temperature of 5 degrees Celsius and relative humidity 35% to 50%. Infection rate was very high, even up to 100%. Whereas when relative humidity was still kept at 35%, but only temperature was increased to 30 degrees Celsius, infection rate surprisingly reduced to 0. That is very important findings. Now, is it true for similar coronavirus genus SARS and MERS? Yes, indeed. Virus remained active for a long time in low temperature. Low temperature significantly contributed to the survival and transmission of the virus, SARS and MERS, shown by various studies, Chan, Song et al., Vandermeer et al., Casanova et al. Now, what about typical air conditioning temperature? A study by Chan et al. Showed that SARS could be active for at least 5 days in typical air conditioning environment, which has relative humidity 40 to 50% and room temperature 22 to 25 degrees Celsius. Now, using similar generic coronavirus, example SARS-CoV, was studied by Casanova et al. Using variable temperature. They showed inactivation of virus was faster at all humidity level if temperature was simply raised to 20 degrees Celsius from 4 degrees Celsius, and it is more rapid if the temperature was further increased to 40 degrees Celsius from 20 degrees Celsius. COVID-19 is extremely contagious and invaded most of the globe in less than 2 months. Hence, it is important that we understand the nature of its transmission under variable temperature condition too. Are there any clinical trial experiments to understand airborne and contact transmission? Yes, there was a lab experiment with guinea pigs. The study was conducted by Loyan et al. They used similar seasonal airborne virus to study the effect of temperature on airborne transmission as well as contact transmission. They found increasing temperature prevented airborne transmission but not contact transmission. When guinea pigs were kept in separate cages at temperature 30 degrees Celsius for 1 week, no recipient guinea pigs were infected. However, if those were kept in the same cage to simulate contact transmission, between 75% to 100% became infected. Interestingly, there was no role of humidity found in those experiments. Thus, we can arrive that contact transmission plays an important role in all temperature. From the outline, we now covered 2 sections, and now let us focus on the solution part. Based on our earlier discussions, some general measures can be proposed. Number one, using sauna facilities. Usually hotels, gyms, leisure centers contain existing sauna facilities. However, after sauna, if surfaces of outside public places are touched, hand washing should be mandatory. Number two, portable convector room heater. Stay close to a convector room heater and inhale hot air at least 2 times a day for around half an hour each time. Of course, keeping comfortable. It would be very useful at the initial stages of the disease. Number three, disinfect any place using high temperature. Before start of office, school or business, temperature of premises may be kept very high, say for 60 degrees Celsius for half an hour. For airport, train and bus, the same method of disinfecting could be thought of. Of course, optimum temperature and duration can be tested very easily. Number four, using blow dryer or hair dryer. For minor symptoms, inhaling hot air intermittently through the nose, of course keeping comfort level, even for 5 minutes, say 2 to 3 times a day, will also be useful to kill virus in the nasal cavity. And finally, hot drinks. For very mild symptoms, take hot drinks. It could be tea, coffee, it could be warm milk or hot water with lemon, etc. Few times a day to destroy virus in the mouth and throat. Gargle with warm salt water at least 3 to 4 times a day will be very beneficial. Hot soup will also be very useful. Why we are proposing such measures? Because the virus is very sensitive to temperature. It mainly enters through the nose, and testing is done with swabs from nasal cavity and back of the mouth. If we can reduce viral load in those places where it largely accumulates, the body will have time and strength to defend against the virus. And very important point that only even convector room heater and warm salt water gargle hot drinks can serve the main purpose. Based on our knowledge that the virus is very sensitive to temperature, we propose some solutions. Now we are presenting in a form of flowchart. Right hand side shows how we can improve the situation based on our individual actions, and left hand side shows for public level how the situation can be improved. Here are some caution and additional points. For caution, if people already develop major symptoms, then all these methods discussed will not be effective and proper medical advice need to be solicited. For additional points, I just like to mention that for very warm countries, some countries already reach temperature more than 40 degrees Celsius in July-August. In that uncomfortable temperature, people use more air conditioning. That low temperature in confined spaces can increase transmission. Here I am mentioning two new papers that further strengthen temperature-based solutions. First one is a peer-reviewed paper on clinical trial experiments following heat-based solutions. It is published and the ethical committee didn't find any issue and approved it. Another paper did a thorough literature review in support of heat-based solutions to fight COVID-19. Being a medical doctor, that author discussed various mechanisms involved in the biological process. We have now covered pre-vaccination period and some solution part. Now we are focusing on some analysis on post-vaccination period. Some questions were raised via Rapid Response BMJ on 21st of March. What questions were raised? After initiation of vaccine program, almost all countries experienced a sudden surge and most countries had to impose strict lockdown measures. Next, even for UK and Israel, where massive vaccination started first, total deaths in 3 months after vaccination reached overall deaths of past 10 months before vaccination. A highly populated country, India, was having a steady decrease for 5 months. India passed major festive seasons where social distancing was very difficult to be maintained. Still, cases and deaths continued to decline. Vaccination started on 16th January and from around 16th February, India started showing a rise in cases and thereafter deaths. What about for Brazil, another highly populated country? Vaccination started in mid-January and a sharp rise in cases is observed since mid-February. Such a steep rise in deaths in Brazil that never happened in the whole period of pandemic. Now, global daily deaths and cases showed an unusual rise during the post-vaccination period. This is a temporal plot for daily deaths and 7-day moving average are shown by dark thick line. We can see that post-vaccination period there is a clear distinction between deaths from pre-vaccination period, and the pattern is consistent for the cases as well. We also notice that two highest peaks occurred after the start of mass vaccination. Peak in the last winter just after the start of mass vaccination, which was initiated 8th of December 2020. It was the highest peak of all. It didn't return the pre-vaccination stage yet. Even March vaccination doses were administered. And we also need to mention that globally cases started increasing after 5 weeks of a steady decline, and coincidentally the period of rise matches when mass vaccination was initiated. Some interesting points. Number one, highest vaccine dose so far was administered in total the country India. Another point, since mid-April, United States, Israel and UK all decreased vaccine dose. In this slide, I would like to show that seasonality and lockdown also has effect. Top plot shows daily deaths 7-day average, whereas bottom plot daily vaccine dose 7-day average. We chose 3 countries. Those are most highly populated countries. Number 1, United States, then India and Brazil. Now, when there was a start of vaccine dose, Brazil showed a rise in deaths, whereas India, it was a bit steep fall in deaths and cases. It became stagnant after the vaccine dose started. Now, when there was a sudden increase in vaccine dose, we can see around mid of February it started. Brazil showed a sudden rise in cases as well as deaths, whereas India reversed the trend. Earlier, the death was showing a declining trend, whereas it started an increasing trend. That rise in deaths as well as cases that happened afterwards, it never happened in the entire pandemic. In India, you can see the rise in deaths was so steep, and after there was and it was also for India, it was also the highest peak of the entire pandemic. During mid of April, US as well as India decreased vaccine dose, and afterwards there was a very steep fall in cases as well as deaths were noticed in India. And probably because of the high population, India always show a certain lag between cases and deaths, and now we can see for vaccine doses as well there is a usual lag between those features. Now we can see that there is a very stiff rise in vaccine doses in India. It started from beginning of June, and the steep fall in deaths now became stagnant. One interesting point to mention here is that lockdown measures are still in place, and if this kind of steady rise in vaccine doses taking place, India is expected to face another wave, third wave, and we have to watch but whether lockdown measures can mitigate that situation or not. But it is worrying because that steep fall in cases as well as deaths are no longer seen for India. Whereas for United States, now we can see that seasonality has showing some effect here. Some plots are present that shows the synchronization of cases with vaccine doses. This is a time series plot of vaccine dose and daily new cases. Both are plotted 7-day average. Right hand side of every plot shows number of vaccine doses, whereas left hand side number of cases of 7 days average. In the right hand side, India, Thailand and Cambodia are presented, whereas left hand side of these plots are for countries Taiwan, Bahrain and African countries. What we can show here, for all these countries there is a very strong synchronization with cases and vaccine doses. For Bahrain there is a steep rise in cases for side by side with the vaccine doses, and there is a very steep fall of the number of cases when the vaccine doses were reduced. For India, though there is certain lag we can see from this plot, probably it could be due to the high population in India. Only 6 countries are presented here, but there are many more countries that are consistently showing such kind of features. Now some discussion on vaccine equity and increase in doses. Here is a country, Indonesia, that is showing highest daily deaths in recent period. What we can see, the few consecutive days, there are highest daily deaths among world, 1093 on 18th of July, 1338 on 19th of July, and it is second highest in cases among the world. We can easily see the number of vaccine doses is so closely synchronizing with number of cases. Now I will discuss some resemblance with flu and some useful, timely, urgent insight. In spite of differences, there are striking similarities between flu and COVID-19. Here I am quoting from a medical journal. Flu season occurs in the fall and winter. In the US, that means October to March, and in the southern hemisphere, it is June to September. Although the reason for the seasonality is not entirely understood, influenza virus has been shown to survive longer at low temperatures and low humidity. Other suggested explanations include weakened host immunity due to decreased sunlight and vitamin D, and increased exposure to the virus due to indoor cohabitation in the winter. I would also like to mention that beginning of winter, old and vulnerable groups are vaccinated against flu in Europe and North USA, but still it is not yet been possible to eradicate flu. On the contrary, it became more destructive in later years in spite of many new vaccines. CDC estimated 61,000 deaths in US during 2017-18 from flu, which was higher than any season since 2009. Flu vaccine ineffectiveness in excess of 50,000 deaths were reported in UK and EU in 2017-18. It was highest in 40 years. And what was the reason? The reason the virus was mutating. Hence, question arises, could it be similar for COVID-19? Following our past experience, it can be speculated beforehand. This is a plot for flu season in US. It shows that flu peaks in winter months and maximum occurrence happens in February. This is the data for 36-year period starting from 1982 till 2018. For COVID-19, also we observed that last winter, US, northern US and European countries had a peak during February. Here are some record of flu earlier versus later period. During the peak month, February, data considered middle of February from CDC. Top plot for later period. A is for 2017-18, B 2016-17. Bottom two plots are for earlier period. C 2009-10, D for 2008-2009. When flu is very strong and active, those places are shown by dark brown and orange, whereas it is less active, it is shown by green and dark green. Top two plots are dominated by dark brown and orange, whereas earlier period, the bottom two plots are dominated by green and light green. Now, we are not yet been able to eradicate flu. On the contrary, it became more destructive in later years in spite of many new vaccines. What are the main reasons? Because the virus is mutating over time and space. We are observing similar pattern for COVID-19 in earlier versus later period. Top plot is spatial pattern and bottom plot is temporal pattern for the mutation of the virus. Top 10 major virus mutation timeline are progressing at a very rapid rate since December 2020. In four rectangle in the bottom plot are showing for 4 different months. First one for November, then December, then January, and then February. 2020 November, the numbers were very less for all top 10 major virus mutations, whereas the rest three, it is progressing really rapidly compared to the whole 8 or 9 months till November. One hypothesis was proposed by Professor Benini Us. He mentioned the time between initial vaccination and second shot to maximize immune response might serve as a sort of breeding ground for virus to acquire new mutations. Now here are some discussion of early stages of vaccine. We need to have critical judgment. People started boasting about success of vaccine following the declining trend of UK and Israel. Here are two plots. Top for daily deaths per million, 7-day average. Some selective countries are shown here. All are showing peaked in winter, like fluid peaked in February. United Kingdom, Germany, Israel, South Africa, and Denmark are shown here. The bottom plot is cumulative vaccine dose of the same 5 countries. What we can see here that UK and Israel had highest vaccine, though daily deaths higher at the beginning of March. Now South Africa had nominal vaccination, but daily death though peaked higher than Israel, but fell at much faster pace and even lower than Israel. Thus, we need to have critical judgment to understand vaccine success. South Africa started vaccine end of February, whereas United Kingdom started 8th of December, and there was a very high vaccination dose for UK and Israel. Further discussion on seasonality, vaccine and lockdown. The top plot is for South Africa. Red color shows number of vaccine doses 7-day average, and blue for daily cases 7-day average. There is a strong synchronization between daily vaccination dose and daily cases for South Africa. Bottom plot is for daily cases 7-day average for all those three countries: United Kingdom, South Africa, and Israel. What we see from these plots that Israel and UK and South Africa all shows a rise in July 2021. In South Africa, vaccination dose suddenly increased in later period and strong correlation with cases is noticed. In Israel and UK, there is no lockdown at the moment. Is vaccine dose matters? Here are some analyses with 5 Asian countries. Top plot shows share of people vaccinated against COVID-19 and bottom plot cumulative deaths per million. 5 countries are shown: Maldives at the top, then India, then Nepal, and bottom 2 for Pakistan and Bangladesh. Maldives received maximum vaccination. Share of people fully vaccinated are shown by dark green, whereas light green shows share of people only partly vaccinated. There are huge difference in vaccine doses of Maldives compared to the rest of the 4 countries. Maldives ranked topmost, whereas Pakistan and Bangladesh ranked in bottom 2, not only in vaccine doses but also in terms of deaths per million. The ranking of those 5 countries are still maintained in terms of vaccine doses and cases. A sharp rise for Maldives in later period is clearly noticed. We also need to ensure that vested interest groups are not overpowering the process of scientific integrity and transparency. Why? Because this is a publication from Forbes. It showed that there are 40 new billionaires who got rich fighting COVID-19. And that's why there is an interesting read. Will COVID-19 vaccine save lives? Current trials are not designed to tell us. I found it very interesting coverage of the vaccine situations. Now, one proposition can be, if there is any crisis or emergency, it should be made not for profit. This is true for all vaccine and allied industries. Policymakers and scientists can think about this proposition for future implementation. Now, to summarize the result, we can tell the most favorable state for spread of the virus was moderately cold places and countries, whereas warm countries are likely to be less affected. For analyzing vulnerability, deaths per million was considered as a useful and effective metric. Statistical analysis in the earlier period suggested that vulnerability to the disease was significantly different between moderately cold, severe cold, and warm countries. Main findings are consistent throughout the period before the start of mass vaccination. Next, we discussed, based on variation of temperature, countries can even switch from one vulnerability state to another. There is a clear distinction for winter and summer in countries of northern and southern hemisphere. Like other similar category viruses, this virus is also very sensitive to temperature, shown by various statistical analysis and clinical trial experiments. It gives valuable insight that regulating temperature can provide a useful strategy to stop and arrest the outbreak. Now, continuation to those results. After the mass vaccination program, there are certain deviations. I addressed issues like seasonality, indirect consequences of mass vaccinations, and fast mutation of the virus after mass vaccination. I showed some countries even showed synchronized pattern between cases and vaccine doses. Those require urgent investigation about indirect effect of mass vaccination. To develop useful timely insights, some similarities between COVID-19 and flu received attention. An alternate pragmatic pathway based on heat-based solution is mentioned, which was proposed as early as 17 March 2020 and is practical without side effects and no vested interest involved. Here is the article. The DY is mentioned here. It discussed the situation in post-vaccination period, whereas these articles discussed pre-vaccination periods in details. Here are all the references that I used in this talk. At the end of the talk, I couldn't resist mentioning the quote from Professor Richard Feynman. He mentioned, "Education isn't about the ability to remember and repeat, in which people study to pass exams and teach others to pass exams, but nobody knows anything. It is the ability to learn from experience, to think, solve problems, and use our knowledge to adapt to new situations." Finally, thank you all